Okay, perfect. We are live. So, good evening to people in India. Good morning to people in the US. I know this is very early, you guys, 5 a.m. But we are down in the evening, 5:30 today, fighting some natural disasters in India today, apart from Corona that has been going on for about 2 months now. Today we start the Bioclear month, wherein we'll have 4 webinars by Dr. David Clark, Dr. Abdul Rahman, by me, and our panelists for the next 4 weeks. Wednesday we meet. From the next Wednesday on, this schedule would be 6:30. So we start an hour late because this is too early for people in the US. So we start an hour late. Clark will be joining us today as the panelists here. We have Dr. Rumpa Vig. Ma'am, can you say hi to everyone? Okay.
Hello.
We have Dr. Abhishek Mahajan, who will be helping us. Dr. Clark will be here with us in 2 minutes. Ma'am, we can't hear you.
Am I audible now?
Yes, yes, ma'am. No, it is. Good evening, ma'am.
Which page you are live in the Facebook so I can share the live?
World Dental Association. World Dental Association. I'll send you the link. If
I'm sharing it.
Okay. Good evening to all the members and good evening to all the friends here in India. We are expecting David Clark's anytime. And I would, on behalf of all the members and admin team, I would like to welcome Dr. Abdul Rahman Tawfik on our page. He has lectured in India in the past as well, and he has been very helping to all of us in the past, and he's always ready. Welcome, Dr. Abdul, to the platform.
Thank you. Welcome, everyone. Thank you.
Yes, there is some issue. We're not live right now. Yeah.
We are live, I suppose.
We are live. We're going on.
Yes.
We had someone message us. Yeah. So I got a message that the live ended. I guess we got to go back live.
What's that? Okay, good morning, everybody.
Good morning,
sir.
Dr. Clark. Good to see you. So early in the morning.
Yeah, just a little tiny bit.
Yeah, I need a huge cup of coffee.
Very big coffee.
Yeah.
Hide that.
All right. I believe we are not live on Facebook.
We'll be live on Facebook in just 1 second. I need to do that in a minute.
All right. Just let us know once we are live.
Okay.
So, sir, how have you been?
Very well. It's been a while since I've seen you.
Yes, 2 years to be precise.
Yeah.
I was at the center exactly in June.
Oh, was it in June?
Yes.
How many people do you think we'll have today?
We should be having a large number today because the audience in the association is about 80,000 at least. That's about 80,000 dentists.
That's a lot of
Big
people.
number. Yes.
So you're back again to the office, Dr. Clark?
Yeah, we are finally. What's going on with you?
Oh, we didn't shut down, actually. Still working. Yeah, the government laid that for us. So if you want to do work, it's up to you.
Yeah, well, your government was a little bit smarter than our government over here. Gee. Okay.
No offense against Trump.
Yeah. Well, yeah. What?
Okay.
Are we ready?
Yes, we are. I believe we are
Good
live
evening.
now.
Good evening once again, everybody. And welcome Dr. Clark, Dr. Abdul, Dr. Pratik, Dr. Rumpa ma'am to the show. And I am very happy to have Dr. Clark with us live today. I would request Dr. Pratik Gupta to introduce Dr. Clark, please.
Hi, thank you, Dr. Abhishek. Dr. David Clark is the founder, president of the Academy of Microscope Enhanced Dentistry. Am I right there?
Yes, I was. Yes.
And he's somebody who's been an inspiration to me to start off with microscope. I had my first microscope about 5 years back, and he was one of the prime reasons for me buying one. He is the president at the Bioclear Matrix, and he is the co-director of the Bioclear Learning Center. He has been my guru for the past 3 years now. He's taught me everything that I know about Bioclear, about composites, about minimally invasive dentistry, and I cannot wait to learn more from him. We also have today with us Dr. Abdul Rahman Tawfik from Egypt. I believe he's in lockdown, so hopefully we get some inputs from him also. He's completed his training, and he is now a full faculty at the Bioclear Learning Center, as I know.
Yes.
Hi, Dr. Abdul. We also have Dr. Rumpa ma'am with us, who is a key opinion leader at Pulbent, and she's been a great support for Bioclear in India. So I just wanted her to be with me today. That's one of the reasons she's here. So I believe we are up and ready. The floor is all yours, Dr. Clark.
Good. Good morning. Good morning. The first thing I'd like to do is I would like to hear from my good friend Abdul Rahman from Cairo. If we could go ahead and it is always wonderful. We have so many dentists come from all over the world here to my little town of Tacoma, Washington. It's not a big town. It's not New York City. And it's beautiful to see so many amazing clinicians come all the way out. And we have a family. This is a family. So welcome to our Bioclear family of great doctors who care. And we are disrupting the old house that was built on dentistry. That foundation was built on that set by Dr. G.V. Black 200 years ago. And that foundation is completely broken. And so we started fresh. And so welcome everyone. I thought it would be interesting. We're going to see some work a little bit later by Abdul Rahman. Now, Abdul Rahman, I didn't download those presentations. Can we go into a share screen to see your presentations later? Can we do that?
Yeah, you have it in my PC.
Okay,
Yeah.
so we're gonna have a little bit of fun today. It's all about showing clinical cases and problem solving. And so we're also going to be doing some live demonstrations here in just a little bit. We'll be doing a live demonstration through the microscope. Are we able to take questions today? Or do we have a Q&A area, question and answer? Can we do that today?
Yes. Yes.
Yes, we will.
Yes.
So we are live on Facebook, so they need to do the questions and answers through Facebook.
I will ask the
Yes.
questions on behalf of the people who are commenting. I will ask the questions on behalf of people who are commenting in the live stream.
Oh, so you'll make the comments on behalf of the people. Perfect.
Yes.
Okay.
Perfect.
Right. So good. We encourage folks to ask questions. We won't be able to answer all of them right away, but we'll do the best that we can. We want to have a nice conversation today. So let's go ahead and get started. I'm going to go ahead and do some slides of a presentation that we do for a hands-on class. So I'll be doing some of these exercises on the dentiforms here. We will switch screens for that. What time is it in India? It's evening time?
Yeah, it's evening, 5:30 in the evening today.
What about Cairo? What about in Egypt? Can't hear you.
You are mute, Dr. Abdul.
It's like afternoon, 2 p.m.
Okay, good. So nobody should be falling asleep. It's not that late, right?
No.
We are having a cyclone in some parts of the country, and it is too difficult to sleep in the middle of the cyclone.
Good. No one can sleep. All right.
Yeah.
Okay, so here we go. What's that?
Perfect.
Share screen. Okay, perfect. So I'm sitting at the base of beautiful Mount Rainier. This is our this is our image that we use for our learning center. Each learning center has to pick a landmark from their area for their background for their learning center. So I'll be curious to see, Abdul Rahman, what your photograph is for Cairo, or what you're going to pick for your beautiful background. We have some great partners that have helped us to build the new model for composite dentistry. And I want to thank 3M and Comet. We'll be using some of the Comet burrs. They've been very supporting for the research. And we will make sure that everyone has access to the research that's been done on the Bioclear method. But today is all about how to do it, what matrix to pick, what do you do on Monday, what do you do tomorrow, how do you bring about these beautiful life-changing restorations that are less invasive than porcelain with indirect. So these are our 4 learning centers, and you're welcome to travel here. We look forward to seeing you, or in Cairo or Sweden or England, and hopefully we'll have a learning center at some point in India. If you would like a little bit more information about the presentations today, you can email solutions@bioclearmatrix.com. You'll get a link, and then once you get that link in your email, you click on that, and then there are many folders. You'll have to kind of look around, but there are many folders that have videos and lectures, things that you can read later. And so I welcome you to do that, to learn a little bit more. So I wanted to show these outcomes, and really it's all about long-term clinical outcomes. One of the problems when you see a case posted on Facebook, they have a 2-second post-operative view, right? That's silly. That's just showing off. What happens 10 years later? How many times have you seen someone show a layered composite 20 years later that worked? They almost never work. And so there's a disconnect between sometimes what we call a doctor-centered outcome versus a patient-centered outcome. And these are new conversations. So on the top, this is a case, and we're going to be talking about posterior composites, and then down the road, the last 2 webinars about how do we get to a good long-term outcome. So in the United States and North America, we do a lot of crowns. In fact, we do way too many crowns in North America. It just has to do with the culture. And so there's a story with this guy. I told him he needed crowns. This was my good friend, Jim. And Jim says, hey, I don't want crowns. And so 2 years later, I said, hey, Jim, we're not going to do crowns on these teeth. We're going to do Bioclear. We're going to do calla lilies and cuspal overlays and put these teeth into compression. And he's a bit of an engineer. And he says, David, that makes sense. So here is his 10-year post-op. These are cuspal overlays and calla lilies where we put the teeth into compression, and they're very comfortable, and they're not perfect, but I'm happy 10 years later. That's a 10-year outcome. And the beautiful thing is so much of the tooth volume is still there. We get in such a hurry to drill the tooth down. What happens 50 years later? As a patient, this is what you want: comfortable, strong teeth. And if something happens, I can do more dentistry later because there's so much tooth volume still there. So minimally invasive dentistry is an okay word, but we need a plan. You need a plan. If you don't have a plan with minimally invasive dentistry, sometimes it's worse. Sometimes minimally invasive dentistry can be worse if it fails. So there you go. And the bottom, this is an orthodontist that flew out from New York City to Tacoma to have her black triangles treated. So we're going to be talking about anterior aesthetics, the fun stuff today, in here in just a little bit. That's a 6-year post-op. And when you take a look at these post-operative radiographs, this is the shape of pink and white. When you can grow pink tissue in a healthy way with Bioclear, change the emergence profile, support the soft tissue, have it fill in those embrasures, There's something very beautiful about pink and white. And so, let me ask Abdul Rahman. Abdul Rahman, can you open up your microphone?
Yes.
When you first saw some of these post-operative x-rays of margins that were better than gold, did you think that's impossible? Did you think this Dr. Clark is a crazy guy? What did you think? Because you're a skeptic. What did you think when you first saw these things? And then I'll ask the same thing with Pratik. Go ahead.
Yeah, actually, the first impression came to me is that I want to do this. I want to have this kind of margins. But the thing is, I thought can I do it, or it needs long life training to do it. So when I started to do the method first, like 6 years ago, I got the margin with some defects, but I got almost the margins. Yeah, it's applicable. It's for the tiny dentist like me can do it. So we can do it. So yeah, it's about details. Bioclear give you the details that will last for the patient for long term.
Yeah. So Pratik, what was your first thought when you saw this years and years ago?
Frankly, I thought that was hard to believe. 10 years post-op on composite like that was difficult to believe in. Because what I was told was composite was a transitional material. It would last for 4 to 5 years, and then you would have to eventually put up crowns there because those last. Composites do not. And when I saw this, when I was at the center, and I was a couple of days earlier, and you showed me some of these cases in your personal computer, and I was shocked. And I thought these were now possible, and probably I can learn this.
You know, what's funny, this is important. I want everyone to listen very carefully. I want you to listen very carefully. In the old world, 50 years ago, the doctor was the boss. The doctor made all the decisions, and the patient said, yes, doctor. Today, the patient is the boss. The patient is choosing. And so I had a patient come to me for a consultation. They needed a lot of reconstructive work. And I said, I can do crowns or I can do Bioclear. This is very important. I can do crowns or I can do Bioclear. And the patient asked me, which one will last longer, the crown or Bioclear? And I said, stop. That's not the question you should be asking me. The question that you should be asking me is, which procedure, Bioclear or a crown, will help me to keep the tooth the longest? Think about that. Which procedure will help me to keep my tooth the longest? And then the patient said, okay, which procedure will help me to keep the tooth the longest? I said, absolutely Bioclear. All the science will show you that the more the tooth gets reduced, the shorter the lifespan is. So not only is it about how long will the restoration last, but the better question is how long will the tooth last? Because once the pulp is dead, the tooth is never the same. Once you cut along the gum line and change the biomechanics of the flexure of the tooth, you get cyclic fatigue, the molecules change, and then years later, the tooth can break off. So we're looking down the road for our patients, and nothing's more beautiful than these additive cases. So I'm really excited that you're going to be able to bless the lives of your wonderful, beautiful patients who trust you. Your wonderful, beautiful patients who trust you to do the right thing for them. That is the most beautiful thing about being a doctor, is the trust that your patients give you. And we're living in a world that's crazy, you know? And my patients come in and they trust me. I've worked a long time to try and do the right thing, and this is the right thing. So I'm excited, and I'm excited to share it with all of you, my brothers and sisters. Okay, so here we go. What is Bioclear? Bioclear started out as a matrix. And when we first built Bioclear, we used the 50 micron mylar. Now we have the 75 micron mylar that's so strong, it's stronger than steel. And so you're going to have to learn some new techniques, because this HD mylar, the 75 micron, can do anything sometimes. The Bioclear method was built from the matrix. I built the matrix, and then later on we had to build a method for injection molding, and that blew up the world, okay? So Roompa, is that Roompa right there? Yeah, you can unmute your microphone, Roompa. Okay, can you hear me, Roompa? I can't hear you.
Hello.
Hello, Roompa. So I'm going to tell a story. I had a 12-year-old girl come to a Bioclear class. It wasn't at the learning center, but it was at out at a hotel. And a little 12-year-old girl came with her mother to Bioclear. I said, why do you have a 12-year-old? And she said, well, she wants to be a dentist. I said, okay. So I gave the little 12-year-old Susie a model, and she injection molded a peg lateral, a Clark class 2, and a black triangle. Little Susie did a better job than half of the dentists. She was 12 years old. So here's the message. If you want to learn the Bioclear method, you need to forget everything that you've ever heard or even thought about composite. Because the old world of composite, it's fine. It does not help you to learn Bioclear. And Abdul Rahman, would you agree? Would you agree that the old stuff in your head that you thought you had to do to have a good composite maybe didn't help you learn Bioclear? Maybe it got in the way?
Yeah. It will take time. If you come from the dark ages to the Bioclear, you will have to deal with like 6 months for getting the old way to get in the Bioclear, and to know that the right way to do the composite by changing all the protocol that you have been doing for I don't know how much, but it depends how much you, but if you're fresh, like if you're start to do composite just with the injection and somebody tell you to back the composite, you will tell him doesn't make any sense.
So Roompa, we have to be 12-year-olds, okay? So as we're teaching Bioclear, you have to tell everyone, just forget everything. Forget everything. Be a 12-year-old, right?
Yes, yes.
So
I use Bioclear posteriors. I very well use them. I have been using them for 3 years now.
good.
Cannot turn back now.
Perfect. Yeah, there's no turning back.
No
All right. So as we're sharing this information, sometimes people will ask a question from the old world. And it's almost better to say, that's a question we don't even ask anymore because we have a whole new foundation. So anyway, let's go ahead and I'm going to show this first case. This is a case of what we call double trouble. We have identical twins with peg laterals. And so here she is. So this is an article that was on Dentistry Today. And so these are the twins. And so the twins were referred to me to treat their peg laterals. And this is a while ago. And the orthodontist, and so in the United States, we sometimes have folks that only do certain, but they have very limited specialties. So the orthodontist only does orthodontics, never does any composite. He said, I want you to do some bonding on the peg laterals. I want you to do some bonding on the peg laterals. I said, I don't do bonding anymore. I do Bioclear. And this is a while ago. And the guy says, what is Bioclear? He said, I will show you. So I'm not going to do just some bonding on the laterals. So these are the photographs of these identical twins. So let me ask you something then that you can answer Abhishek, right? Abhishek, is that right?
Yes.
Abhishek,
Yes.
So you can help me. I'm going to wait. The twin on the left is doing something with her tongue. Let me ask the people that are watching, what do you think the twin on the left, this one here, what is she doing with her tongue? Why is she doing that? So let's see what some of the people watching think that the twin on the left is doing with their tongue.
Is she having some tongue thrusting habit? Or just plain?
Now, is that your question, Abhishek, or the question from the other doctors?
It's my question.
You were supposed to wait for the other doctors to ask the question.
Okay.
That's okay. Come on.
No problem.
All right. Okay, Abhishek thinks that maybe she has a tongue thrust problem, you know, whether it's airway or behavioral, that she has a tongue thrust, okay? What other things could she be doing other than the tongue thrust? I wondered the same thing, right? What else could it be? Let's hear from some of the other people.
We are waiting for the people to answer it.
That's okay. We want people to feel involved today, so we'll wait for just a minute.
We have someone say it might be open bite.
Open bite? An open bite?
Yeah, someone wrote that.
That's another idea. Yeah. So we have tongue thrust, open bite. Once people have an open bite, they tend to stick their tongue in there. Yep. Anything else?
Not yet.
Not yet. We'll give them just another 20 seconds. Come on, people. Think.
Everybody trying to close space while speaking.
Hiding the space.
Who said hiding the space?
Dr. Aditi Rathod online
Okay.
says hiding the space.
Okay. All right. Well, they win the grand prize. Okay. So it could have been any of those things. But when I started interviewing the patient, I was taking the photographs, and then I finally took a photograph where she had her tongue back. See, I have another photograph that I won't show you where the tongue was there. I said, please pull your tongue away. And so she pulled her tongue away. And I said, did you know that you're putting your tongue behind your teeth? And she said, oh yeah, I figured this out. I learned that if I put my tongue behind my teeth, that they would look less ugly. Because the negative space, and that's the word I want you to start using, this negative space is not a good space. The negative space should be a nice, gentle curtain like this, not jagged like this, not with all this black where it's not supposed to belong. So negative space to human beings is big. We think that putting texture in the tooth is big. We think that putting 5 colors in the tooth is big. It's not big to patients. This is something that everyone can see. You don't have to be a dentist to say something is wrong. So this poor little girl was putting her tongue behind her teeth. So the orthodontist who referred the patient to me said, David, I want you to do some bonding on the lateral incisors. And to me, bonding sounds like 6 months of longevity, and it costs about $200. And a crown in this area is about $1,000. Okay, so to give you a contrast between, I don't know how many rupees that is, but a crown costs 5 times more than bonding. So the cost is also important. So I said, no, we're not going to do bonding. And so let me ask everyone that's watching. So the mother came to me and said, I want my teeth, I want my little girls to be proud of their teeth. I don't want them putting a tongue behind their teeth. I want you to treat them. And she was just learning about the Bioclear method. So let's say that you are a master at the Bioclear method. And the mother said, I want you to do an ideal result. I don't want you to compromise. I love my girls, but I want you to try and be conservative. Don't go crazy. It's not Hollywood, but I want you to do the least amount of dentistry to get a good result. So I looked at the case, and in lateral view, this is a very undersized lateral, and I want you to look at the other side and take a look at that. So let's say that you are the doctor and you are going to do the treatment plan. How many teeth are you going to do? Are you going to do what the orthodontist asked you to do and to do just the lateral incisors, or would you do more teeth? How many teeth would you treat to do the minimal amount necessary to get an ideal result? Okay. So let's see if some of the people, let's see what some of the people say about what would you, how many teeth would you do to get an ideal result? And while we're waiting for people to comment about how many teeth they would do and what teeth they would do, Let me go over the goals of the Bioclear method. The goals of the Bioclear method, we have 3 goals. Number 1 is to replace the diseased tooth structure. Okay, so the missing, the undersized, or the diseased tooth structure, that is the first goal of the Bioclear method. Number 2 is to preserve and respect the natural tooth volume and the natural biomechanics of how the tooth flexes. When we cut the tooth, things change. The third goal of the Bioclear method that's very patient-centric is I want to thicken and opacify and brighten the dark, overly translucent teeth. People generally don't like translucency. They want a soft, natural, bright tooth. They really don't want gray teeth. So those are the 3 goals of the Bioclear method: to replace, to preserve, and then to brighten and thicken the tooth with additive dentistry. We're going to make the teeth bigger. Okay, let's hear, do we have any treatment plans from the doctors who are watching?
Yes, lots of answers here. Only lateral, some consider they will treat from canine to canine. Some say only for the centrals and the laterals. One answer here is dividing the space between 2 teeth. So 4 teeth total.
So we go between 2 teeth, 4 teeth, and then 6 teeth, right?
Yeah.
6 teeth.
Yeah. Yeah.
Right. And so for me, the thing that kind of kicked the case, and so my answer is, in my case, I did 6 teeth. And when I started, I thought I was only going to do 4. So I was on my Bioclear journey. I thought I would only do the centrals and the lateral teeth. But then when I got into the case and I looked at that tooth, then I realized I needed to do the canines too. And the case should be with identical twins because they are identical twins. So if I'm going to do the canine on the left side, then I need to do the canine on the right side. So I did 6 teeth. And this is the matrix that we chose. It was DC202, DC201, DC203. We'll show you those matrices. These are the diastema closure matrices in the original Bioclear kit. And this is the DC202 right here. I'm going to show you a peg lateral. We're going to go ahead and do the procedure on the peg lateral in just a minute. And we're going to show delayed wedging. And so that's the Bioclear aquarium. It's so much better when you're doing Bioclear if you, at a certain point, it's easier to do what we call the aquarium. Does everyone know what an aquarium is? Yes? Aquarium?
Where do you place fishes?
Yeah, where you place fishes, right. It's this glass thing. So we love to call it the Bioclear aquarium. When you do an aquarium, you get better thixotropic flow, better control of the case. At first, when you first start Bioclear, you think, it's going to be so messy. There's composite everywhere. And you think, it's bad. And then someday you wake up and say, no, the aquarium is good. It's not just a place to put fish. It's a way to do injection molding. So, so here's the preoperative, and here is the aquarium. And this is called delayed wedging. We're going to go ahead and do that here in just a second. I'm going to go ahead and blast the tooth. We've got a rubber dam on. We disclose, we blast the tooth. It's part of the Bioclear method. We're going to etch, rinse, and dry. We're going to put heated flowable composite about 1.5 millimeters around the tooth. I'm going to hold the matrices in place, and we're going to cure that. And then we're going to put diamond wedges on the mesial and distal. Diamond wedges are amazing because they're so much stronger than a wooden wedge, but they don't traumatize the soft tissue like a wedge. So it gives us the best of both worlds, very strong separation, and then we can not traumatize the tissue. And then we're going to do the second increment where we're going to injection mold after we pull the matrices apart. So delayed wedging allows us to get great contact. So we really want to learn about delayed wedging today. We don't use it all the time, but it's a very powerful tool. There's the immediate post-op, and those are infinity edge margins. Now, these girls are 13 years old. These girls are 13 years old. And we know that the soft tissue is going to migrate apically. If you have a margin, that's going to look ugly. This is the infinity edge of Bioclear. Now, sometimes people say, David, you need to layer these teeth. You need to put texture on these teeth. You need to do all this stuff. Let me tell you something. The transformation of these teeth for these twins was amazing. So this is a funny story. This is the twin on the left. She had her work done on Tuesday. And here's the twin on the right. It's Wednesday morning. She's about to get in the chair. So I made a little movie. I thought it was pretty cute of the one twin that was all done on the left and then the twin on the right. You can see what a major change it was for their smiles. And then, so here they are pre-operatively. Here they are post-operatively. Here we are pre and post-op. And here is their 3-year follow-up. They're growing up. They're now 16 years old, taking selfies all the time, right? I mean, how many selfies does a kid take these days, right? And then here they are at year 7. So that's they're now 20 years old. And so people would say, oh, you know, not patients, but sometimes if I give a lecture in Italy or someplace, some guy will say, oh, Dr. Clark, you need to put texture on the tooth, or you need to layer the tooth. That just weakens the tooth. It just attracts biofilm. Patients don't want it. And from a socially acceptable distance of a couple of feet, the teeth are exactly what I wanted, which is to preserve the natural tooth, add the missing volume, and make the tooth wider. People like bright teeth. So let me ask what the doctors think, because here's the thing. I'm curious about what the doctors think, Pratik, but I don't care very much, because the little girl here on the left, no, this girl on the right, I believe, she was voted the most beautiful smile in her school of 1,000 kids. They have a contest. Who has the most beautiful smile? She had the most beautiful smile in the whole school. So if some doctor doesn't like it, I don't care, because the patients love Bioclear. And who's the boss? Who is the boss?
Patient.
Patient. And the pulp, right? And the soft tissue. So for me, that's the ultimate victory. So let me ask the people what they think about how we manage the space, and how you know, does it look good? You know, was it successful? Let me see what the people say. Let's see what they think about these.
Some replies coming in. Looks great, amazing, super job, wonderful results. So I believe the doctors are also happy, as happy the patient is.
Yeah, sometimes when you lecture to dentists, they want to say, oh, it's bad.
I know, no texture.
It is most difficult to convince the dentist, actually.
Yeah.
We are microscopically involved.
What's that?
We are too microscopically involved with the teeth.
Yep. And we make mistakes and we harm our patients. We hurt our patients because of our biases. We have aesthetic biases from looking too close that make us make bad decisions that harm the patient. We do things that are too aggressive or things that don't last. So there's a message, everybody. There's a revolution, and the revolution is a patient-centered outcome. We need to listen to them and quit sometimes listening to the negativity of dentists about microaesthetics or other silly things. Okay.
I needed to tell something. So I'm actually talking to you guys from a dental lab, because I'm taking courses now for how to do ceramics, how to do build up with the ceramics, to do some stains. So since the lecture was in the afternoon, I stopped to all the guys in the other office doing the hands-on for the staining. So I did for the last 2 days ceramic build-up, staining and glazing, and with my loops, I was able to see a lot of voids that I have to remove before, you know, firing all this kind of stuff. The same happened with the composite if you do layering inside the patient mouth. But with the ceramics, you have the ability to re-add, to fix, to do a lot of this kind of stuff. So composites inside the patient mouth, you can layer for sure, but how much time you need to do it perfectly, and how much time you need to learn how to do it perfectly. So even if you're an expert, a lot of mistakes might happen, micro details that you can find when you do polishing, like in ceramics. So the doctor that teach us how to do ceramic build-up, before glazing, you have to polish it. So if there is some voids, you have to remove it and to do some buildup again, and before, so the glaze will be done in the final non-porous layer. With the composite, it's not applicable in the patient mouth. This is my thoughts.
Okay, so one question that has come up here is, no tooth was prepped for this case. How about the occlusion?
The occlusion was not changed. So what happens is, on the palatal surface, we take the bite back to the MIP, the MIP, maximal intercuspal position, whatever you want to call the native bite. So on the lingual of these teeth, once I injection overmolded the teeth, I closed the case down so that all the teeth were touching on the enamel. So on the palatal surface of every one of those teeth, they have a little tiny blue spot on the natural enamel. But everywhere else, in protrusive and all the excursives, that's composite, that's in compression. And anywhere where I added the incisal edges, we added at least 1.5 millimeters. So when the composite is monolithic, it can tolerate compression. And then here in tension, if I have the 1.5 millimeters of thickness and then 2 millimeters buccal lingually, they don't break. So the answer to the question people always ask, I always forget, is what's the bite? No, the bite is on native enamel in CR or MIP. And then that vertical does not open, but then in excursives, monolithic composite is incredibly strong. Monolithic composite is as strong as Emax press, 365 megapascals. If you layer it, it's super weak. So monolithic composite can really hold up, but I always forget that people think that I opened up the bite. Sometimes we open the bite, but I did not need to open the bite in her case. Good question. That's a good question. Are there any other? What? Oh, zero preparation. Zero. Sometimes we have to prep the teeth, but in this case, there was no need to prep the teeth.
What is the life of this as compared to porcelain?
Well, what will help keep the tooth the longest? What will help the patient keep the tooth the longest? Bioclear. Okay. So the longevity of this should be about the same as porcelain, 20 years. Okay. It could go, I've got cases that are older than 20 years now. So, but the question that doctors always ask is, like I said, what's going to last longer, this or porcelain? What's going to be the best for the patient? This will be the best for the patient. Whether we have to do this 3 times over the patient's lifetime or twice or once, we can do it again. You do crowns today, you may lose the teeth tomorrow, but that's the question that everybody asks, right?
Okay.
Perfect.
Yeah.
So we have an
I am so happy that you're asking these questions, because these are the questions we should be having with each other and our patients for the next 50 years. What is going to help the tooth last the longest? Oh, I never thought of that, right? We always think about today. We need to think about 50 years from now, right? Okay, great question. So what we're going to do now is we're going to go back and talk about delayed wedging and matrix choice with the Bioclear method, okay? So these are the classic Bioclear. This is how I think about it and how I teach it. My father used to teach for the deaf people. He would, and so he'd use sign language in our home. So I like to sign. So it is the O1 matrix. So O1, do this with me. Abdurrahman, Pratik, Abhishek, Rumpa. O1, Abdurrahman, O1. Let me see your hand, Abdurrahman. He's asleep. O1.
I can't see you guys.
Okay, all right. You can't see me. All right.
I can't see
O1, and then O2. Show me the O2.
O2,
O2, and then O3.
O3.
Down here on your chin. So the O3 matrix is a very small matrix for lower incisors. The O1 matrix is a very big matrix for the central, maxillary central incisors. And then the O2 is for lateral incisors or the distal. It's very curvaceous. And then O1, O2, O3, and then you have the pink and the green. The pink has a small emergence profile, and the green has a very large emergence profile for diastemas. So let's go ahead and take a look at the case. So we have O1, O2, and O3, and then I'll ask everybody what matrix that they think they might use for. I'm going to do just one peg lateral here today, and we're going to do delayed wedging on this, and we'll show you how the delayed wedging works right here. So this is the hip that we're going to create with the heated composite and do delayed wedging. All right, so let's go ahead and did we already stop share? I have to do it. Okay, you ready? So we're going to be treating this little peg lateral right here. And now normally for our Learning Center courses, we have to sandblast these teeth. I don't really want to prep this tooth because I don't want anyone to think that we cut the tooth to do a peg lateral. We don't. So let me ask everybody, this is the black triangle gauge we're going to use later, right? But we can use this for Bioclear now. So what matrix are we going to use on the distal, the pink system or the green system? Let me ask Pratik and Abdul Rahman, what matrix, pink or green for the distal to close that space?
I will go for the green for sure.
For the distal, green.
For the green. And so in this case, the green is going to work, but I'm kind of talking about this new conversation that's important. With the black triangle matrix, we have 4 curvatures. We have pink, yellow, green, and blue. And so with original Bioclear, we only had pink and green. So classic Bioclear comes in pink and green. But for black triangles, now we have pink, yellow, green, and blue to close the space. So we're going to use the green system here. What about on the mesial to close that small space? Pink or green? What do you think? Pink. Now, sometimes with classic Bioclear, it's a little bit bigger than pink, and so we'll take the green matrix and we'll trim the green to make it more like a yellow. Does that make sense? So Abdul Rahman and Pratik and everyone teaching Bioclear, we want to now start talking with the 4 colors, okay? Because we only had pink and green in the old days. But in reality, when we trim the green matrix, it becomes a yellow. And if we trim it enough, it becomes a pink. Okay? So so on the mesial, let me have an A103 here. Now let's take a look at the size on the mesial. We'll do HD. So
can we just the hands-on video?
What's
that? Large screen.
Okay.
People want just hands-on as a large screen. Yeah.
Yeah. Is the hands-on large screen now? You should be able to do that now. What everyone has to do is you have to go to the speaker view. I want you to pick speaker view, and then that big screen should come up. You don't want to be on. What's the other view?
We are not on Zoom. We are on Facebook Live, so we need to do that.
Oh, it's on Facebook.
So how are they going to switch that? So it should be enlarged on Facebook.
No.
No?
It's not. No.
The microscope feed needs to be enlarged.
I'm not sure how we do that on Facebook. So the microscope feed right now is very small.
Yes, it's a part of the tile.
Everyone's the same size right now. There's nothing we can do to Facebook.
So it looks like we're not going to be able for Facebook to show the image large. It's just going to have to be small.
Okay. No problem. Please carry on.
Okay. Now,
Please, no.
what we're going now, are we going to record this, our portion of this, Zoom portion of this? Okay. So here's what we can do. Everyone can see it with some detail now. And then we're recording this because with Zoom, we can't have more than, 500 people. we're recording this video, so people will be able to watch the video later
Perfect.
with the large screen. Sound good?
Yes. Yes, we can upload it later on. No problem.
Perfect. Okay. So what we're going to do here is I'm going to go ahead and try in the, this is the A103. And what do you think? Do I have enough curvature here to close that space? Can you see it? I don't think so.
No.
No. So let me have a DC203. And this is going to have too much curvature because you can see that the matrix is sitting over here like this. Can you see that? So that's a little bit too much curvature. And if I push it over, it's going to invert the matrix. So trimming of the matrix is a big deal. So we're going to turn this really sort of into a yellow matrix. I'll trim. We always want to make a V trim that looks a little bit like that. If you can see that. And then I'm going to go ahead. Now we've decreased the emergence profile. That's not so bad. When I pull this over, it's still inverting a little bit. So with original Bioclear, it's important to be able to trim the matrix. So let me ask Pratik and Abdul Rahman, when you're using classic Bioclear, how often do you trim the matrix? What percentage of the time? So that's pretty good now.
Like 50%.
50. Pratik?
50% of the time?
Yeah, 50.
Yeah. Remember, whenever you cut the classic Bioclear, you're going to decrease the amount of emergence profile. So you're going to go from a green to a yellow to a pink the more you trim. And then we always trim something that corresponds to the papilla. So depending on the age of the patient, it could be very steep. If it was a young patient, it might be a deep V like this, etc. So we can modify the gum line of the gingival of the matrix and accomplish our goal. So let me have another one of those DC203s because I marked that one. So I'll trim this one more time, and then let's take a look at the, I'm going to use the DC202 on the distal. And in this case, that amount, what do you think of that emergence profile? So this is the DC202. Once again, the O2. So what do you think of the O2, Abdurrahman?
I think it's good. For me, it's good. Perfect.
It's good.
No trimming.
No trimming. Okay,
Yeah.
good. Now, one thing that I like to do is I like to have the matrices the same height. So I'll be trimming these matrices so that I can manage them for delayed wedging. Okay, so let's go ahead and I'm going to, let me have a filter and adhesive.
You want to trim a tiny bit of the facial of that mesial matrix to get it out of the way?
Yeah, we're okay. So this is the part of the procedure until the hip is placed that it's a little bit more challenging. Anytime that we have to do, we have to build a contact. Anytime we have to build a contact is basically a diastema closure situation. And so what's that?
I want to ask you, when you trained it, the profile, did it change? You just wanted to have the same height for the other matrix?
Yes, it's just for management because I want to be able to do this. So I want them to be the same height. That's a good question. Yep. So normally we would etch, rinse, and dry. With Bioclear, we always do a total etch. And then I'm going to take this adhesive. I'm going to come here and make a little tiny purchase point for the adhesive along the gingival. And we do not need to cure this because it's on enamel. And now I'm going to go ahead and take heated flowable composite. And now you can see why I wanted the matrices to be the same height. Right now, they're difficult to manage, but in a minute, they're going to be easy to manage. I'm going to make about a 1.5 millimeter hip of composite to support the diamond wedge. Now, the one on the mesial is a very difficult area. That's a little tiny hip. So the thing you'll learn is the most difficult diastema closures are the small ones. Would you agree, Pratik? Would you agree, Abdul Rahman?
Yeah.
Yes.
So I'm going to take this matrix and I'm going to adjust it for the amount of contact that I want. Now, I don't want a point contact, and I don't want it to be inverted like that. So you have to put medium pressure on that. That is very different than the pressure that we would use for the original Bioclear that was a 50 micron. So I'm going to make the contact pretty broad. I'm pulling both of these over, let's like here.
Just I wanted to add something that people have to
Ali, your sound went crazy for us. Can you ask that again?
Yeah, if you're using the 50 micron matrix and you want to push to increase the contact area, it might invert. So you have to be careful if you're using the thinner matrix when you do the pushing.
It's much more nuanced. Yep. So now we're going to go ahead and use the diamond wedges. The diamond wedges come in small, medium, large, extra large, and then the deep carries or the Ferkel. I'm going to go ahead and try some of the medium diamond wedges. So this is now called delayed wedging, because if we would have done this before, you would not have been able to have the matrix be supported. So now we bring the wedge in, and I'll show you like this. We'll bring it in like so. And again, like so. And then we push the wedge here. And the way we want to do this clinically is like this. And now the teeth have moved over. The canine has moved distally. The central has moved mesially. And now we can sometimes release the mylar from the hip just a little bit. You can hear it click. I just clicked. And now it's free to fill the space. So did everyone see what I just did? I released the mylar and went click. And now we're ready to injection mold with the aquarium. So let me go ahead and have adhesive. I need a big scrubby.
Not the mop.
Either one. Actually, in this case, probably the big scrubby. So now we're going to get the entire complex wet. You don't need to massage it because it's in enamel. We're going to air thin. And then I'm going to bring the flowable in. Now I want to bring it from the lingual so I don't block my view. If I start in the facial, I might lose my way. So that adhesive acts as a wonderful surfactant. This is the area that's very difficult to inject right there. And I'm going to fill this about 3/4 of the way full so I have some support when I inject the paste. And I want to inject the paste into the flowable. And now you can see the flowable being displaced. And I'm going to pump in one more paste composite. We've got some great, Johan Hagman, who's our faculty of Learning Center in Sweden, has a beautiful video where he shows almost all the flowable has been displaced. And I'm not going to make any changes in the distal contact, but I'm going to make a small change here on the mesial. And then let's like here. Hang on a minute. I forgot one thing. You didn't yell at me. It's early here in Tacoma. I'll normally would take a dry brush here and remove any excess of composite that is along the gum line. Can I see a dry brush? So we want to remove any excess of composite that's along the gum line, or any excess of composite in the interproximal that goes on the wrong side of the matrix. Okay, let me see that little paddle, and we'll make an adjustment here. Let's go ahead and cure. Okay, and then go ahead and bring the paddle away. All right, and lingual.
I like this trick. I started to use it too much, so now I'm more comfortable with my contact. So even with the thicker matrix, I get good contact. Yeah.
Yeah. The thicker is so much easier to manage, but but you have to learn again, don't you? Because you have to do more pressure, and just be aware that the mylar is a little bit thicker, 75 microns versus 50. Okay. So I'm going to go ahead and disassemble and say the Clark Explorer. It's important to have the Clark Explorer, something like that, because you need something a very thick shaft to the Explorer. And then you look at the composite, and I'm not going to do a lot of finishing here because right now this is not full screen, but I really wanted to share the delayed wedging technique. Let me see the hemostat. Now, whenever you do this in your classes, the dentiform does not have a periodontal ligament, so you have to wiggle the tooth like this in the dentiform, and then you'll have nice tight contacts. So there we go. And I'm not going to go through the process of how we do the cutback here, but that is a very, very strong, and it becomes basically one with the tooth. And it's the same compressive strength as Emax Press. It's very sort of visually soft. And that's why we like the Filtech Supreme Ultra. It has just the right opacity, because what we understand with the Bioclear method is that the composite is more translucent. And that's a very important thing for people to realize. So that's why we don't use any enamel or omnichroma, because when the composite has no bubbles, the optics are very, very different. So it's so much more translucent, the value goes down. So I don't know, I mean, Pratik and Abdulrahman, you can tell me, but from what you did in the old days, are you picking a little bit brighter shade because of the increased translucency of monolithic composite? And when you put the Rockstar polish on, the value goes down and down and down. The brightness goes down, the translucency is increased. So that's why we love the Filtech Supreme Ultra body shade. I don't know what kind of composites you have available where you are, but we don't use the translucent because it's too translucent when you do this method. So Abdulrahman and Pratik, can you talk about the optics of monolithic composite and the colors that you're picking now? Because it's changed. You have respected the chemical and optical integrity of the composite. It acts differently when it's monolithic. It looks very different compared to layering, because Abdulrahman was talking about this. Those little bubbles that you see with hand layered composite or hand layered porcelain, it completely changes the optics. Those bubbles create a lot of false value. They decrease the translucency. Okay.
For me, I usually go. I use mostly 3M composite body sheet, but at the beginning I was doing a lot of A composites, A shades, A1, A2, and now most probably if the patient wants more white teeth, I go for B1, and if I want to go for patient of age of mine, I go for A2. And like you said, when you do the polishing with the Rockstar, the translucency actually for the body sheet, it's there. When you do the polishing, there is some translucency you can find in the cell edge. So in one of my courses, I did a composite with the white body sheet, white body for the kid like maybe 8 years old or 9 years old for incisal fracture, and I did only body shade. And even though after I did the polishing, there is some translucency in the incisal layer. So there is some translucency you can find. You don't have to use translucency.
The composite works for you. With Bioclear method, the composite and the matrix are working for you instead of against you. It makes your life easier.
Yeah.
Pratik, have you, for all the people that haven't done a lot of Bioclear, what's been your impression of value and because of the incredible translucency that we create with the Bioclear method?
So here in India, we are still matching shades. We do not go white as you guys in the US do. You use a lot of bleach shades, and I know about that. But we still have the regular A2s and A3s, and I tend to use one shade light because of the translucency that eventually comes up. And we get 3M Filtech Supreme here also as Z350 body shades available. So I guess it's more or less the same, but one shade light is what I generally choose.
So Pratik is going up one shade. So instead of using A2, he might use A1, right?
A1, yeah.
Instead of using A3, because it doesn't look the same, it looks darker. It looks darker, but that's a good thing. It's a consistent color and it's beautiful. All right, so I want to show some clinical cases. I'm not going to show any more live microscope because we can't go full screen. So I'm going to show some cases, some anterior cases. Before we move on, were there any questions from the people watching about delayed wedging?
Yes, there is one question from Dr. Vishal Gupta. He says layering is about precision and practice like everything else in dentistry. Still feels class 4 fracture where in the contralateral tooth has obvious opalescence. Doing mono shade will not work for good aesthetics.
You know what's funny? I appreciate his opinion, but I've done thousands of these restorations and people fly from all over the world and they loved them. So his bias is that you cannot achieve good aesthetics with the mono shade. That is a bias. And my bias, because I've done thousands of these things and people are spending, I know it sounds crazy and it's a different economy here, but people that come to my Bioclear clinic, I charge a higher price for mono shade composite than I do for a crown. So what is a crown? How many rupees is a crown? What do you charge? How many rupees?
A max $100 to do a crown.
Okay, so if you're charging, $100 for a crown, right?
Yes.
I'm charging $110 for Bioclear. So the doctor that said, hey, you can't have good aesthetics, you have to layer, I respect his bias. But here's what everybody, your dentists need to understand. Your patients don't care about layering. They only want health and strong and beauty. And what will last the longest for most patients? Bioclear. And so they are willing to, for the doctors doing Bioclear, and you get good at this, they are spending more money for Bioclear than for a crown. And that seems crazy, but Abdul Rahman will tell you, Pratik will tell you that patients, there are millions of people watching these YouTube videos about Bioclear. Patients in India are asking about Bioclear. They don't want layering. I love the people who love to layer. I think it's a wonderful craft, but that craft is slowly disappearing. We don't really see layered porcelain anymore, even though it's possible. Monolithic is the new normal. Monolithic is very normal. So we want everyone to understand how monolithic works. We have 50 years of layering classes, and that's something that will always be around for a certain segment of dentists, but that segment's getting smaller and smaller and smaller. So it's a wonderful art form. We don't want to disrespect it, but it is slowly disappearing. And that was been driven by patients. What other questions do we have about any questions about delayed wedging? Abhishek, any other questions?
Yes, just a moment. Somebody is asking about the.
Go ahead.
Yes, Dr.
Dr. Pratik, please ask your question.
So one of the questions here is, can we use this for a caries tooth restoration as in a class 3?
Absolutely. I'm going to show that right now. So what we're going to do is I'm going to go in and show a bunch of cases, and then we have to wrap it up for today. So let me go ahead and we'll be answering. We're going to be doing Bioclear for everyday class 3s, for black triangles, and the peg lateral, which we already talked about. So let's go ahead and show some cases, and then if we have time, we'll do some more answers, some more questions at the end. Okay, so let's go to share screen here and back to the presentation. Okay. Ooh. I'm lost. All right. So can everyone see the PowerPoint? Okay. So we're just going to show a bunch of cases, and then we'll kind of let everyone judge for themselves. Well, how do they think about the aesthetics, right? So here they are, pre-op, post-op. You saw the twins. Let me just go back to where we were. So in the old days, I had a piece of flat mylar. I put a wooden wedge in there, got a black triangle. It was ugly. So I thought it was great. The patient hated it. So I've been on a journey ever since to create something modern for dentistry. So these Bioclear matrices go below the gum line. It pushes the soft tissue away. You can do layering with the Bioclear matrix. And some people do that, but over time, like with Abdul Rahman, he's doing less and less layering. I think he'd probably agree. We want to move away from flat mylar. Yes?
Yes.
Yeah, the problem with the bonding, traditional bonding, it might look good to the doctor, but when you look at the x-ray, bonding doesn't look very good. It's just different. So injection molding allows us to go around the tooth, to transform the tooth. It's a whole new day. It's an incredible change. It's an incredible change. So the Bioclear method has 5 pillars. Number 1, we have to remove biofilm. We always paint disclosing on the tooth first. The next is modern cavity preparations. In the weeks coming, we're going to talk about the new Clark Class 2. It's an incredible change in the world to get away from traditional cavity preparations. Here in America, they still teach of these GV black preps in half the schools. So it's been a very difficult change. The Bioclear matrices are anatomic tooth forms. They're not really matrices. So they're very specific, different shapes. And as we build more of these, then there's more opportunities to do more things more predictably. Injection molding is the next big part of the method. We have to heat the flowable. We have to heat the paste. It needs to be injected so that we get a very strong tooth restoration interface. And finally, the Rockstar polish. We have to create this unbelievable shine to bring the translucency back to any time we cut the composite. So these are the 5 pillars of the Bioclear method. This is an orthodontist who came to see me. They did bonding on the lateral incisor. You can see that the problem with flat mylar and the problem with traditional hand manipulation without the infinity edge is it's the wrong shape, it's the wrong color, and the emergence profile occurred supragingivally. So with Bioclear, we're able to change the emergence profile subgingivally. So this lady had this work done in another office. I'm going to go in and use the Bioclear method. I'm going to add to the incisal edge. I will move the midline over. We will injection over mold this case. And by the time I'm done, I'm going to do about 24 teeth. So the other dentist did 1 bonding. But if you do the Bioclear method, you can change this entire dentition. And this is 20 teeth. So if you're going to do bonding and do single tooth, a lot of the time it's going to look like that. If you will do the Bioclear method and begin to understand the power of injection overmolding, you get to do big cases, okay? But if all you're ever going to do is single tooth dentistry and spend a lot of time putting texture and layering on 1 tooth, you won't get to do the big, beautiful Bioclear cases that patients want you to do. So I want you to get comfortable. So let me ask Dr. Abdul Rahman, What's the biggest Bioclear case you've done? Dr. Pratik, what's the biggest Bioclear case you've done? What's the most number of teeth on one patient?
For me, I did 14, 22,
22 teeth.
You know,
Now,
yeah,
that probably was
definitely.
not your
One
first Bioclear patient, right? You had to build confidence, right?
Yeah, this is not definitely my first Bioclear patient. No. I think everyone's first Bioclear patient was like maybe class 3, single tooth, the
Yep.
anesthesia, maybe.
Yep. So we start small, we get confident, we go up. Yeah. Pratik, what's your biggest case?
20 teeth, just till the premolars. I still do not have the confidence to go to the molar.
Yep, we're all growing, right? I'm still learning. All right, so this is one of the exercises that we do. We do a class 3. We combine this is the pink system, the classic. We combine Bioclear and peg lateral. So I want to show another peg lateral post-operatively. Here's a 3-year post-op. Here's a 7-year follow-up. So let me back up here a little bit. So the question was, hey, you have to layer to have good aesthetics. So let me ask you this. We're going to build an incisal edge. So this is like a class 4 fracture case where people say, hey, you have to layer for good aesthetics. That was one, and I respect that the doctor feels that way. So let me show you this case. Here's a preoperative peg lateral. There's the delayed wedging. There's a post-op, 3 years, 7 years, 8 years, 10 years, 11 years. So here's the thing. The doctor says, hey, you have to layer. You have to put gray on the incisal edge. I asked the lady, I said, do you like your gray front tooth or do you like your canine better? Because I matched your canine with Bioclear. That's monolithic white, okay? So I asked the patient, do you like your canine aesthetics better or your central incisor aesthetics better? Because a lot of doctors, like the doctor was talking, says, hey, you have to layer. You have to make gray incisal edges or you're a bad dentist. And I said, am I a bad dentist? What tooth do you like better? Do you like your canine tooth better or your central incisor better? Because I matched your lateral after your canine. Let me ask everybody, what do you think the patient prefers? This is her Bioclear tooth 11 years later. 11 years later. Does she like the canine better or the central incisor for color? What do you think? What's her bias? What's the bias of the patient? Let me ask. Let's ask our attendees. Let's ask everyone who's listening. Does everyone understand?
Yes, yes. We're just waiting for the answers to come in.
So this is her Bioclear tooth. And I asked her, I said, do you like the aesthetics of the canine? But the canine was a natural tooth. I only treated one tooth. Do you like the natural aesthetics of the canine or natural aesthetics of the central incisor with the gray edge? What do you think the patient preferred?
Okay, till the answers come in. Here's a question that I would want to ask. How can you follow the tooth proportions on a wax up model using the Bioclear Matrix? How predictable it is?
I'll answer that and then I'll let the two panelists. I don't do a lot of diagnostic wax ups anymore because my confidence in Bioclear is so high. And one of the things that we use is the smile design gauge. Can you grab me a smile design gauge? I showed that smile design gauge briefly. So one of the things that I do is I take photographs. And then the other thing I know that Pasquale Venuti in Italy, he'll use a smile design gauge to decide on some basic numbers. And then he'll put the Bioclear Matrix directly in the mouth, inject a little bit of flowable composite temporarily to look at it. He'll take a photo. So some people still do diagnostic wax ups for the bigger cases, but for most cases, we're not using a diagnostic wax up because the Bioclear Matrix determines all the shape. So that's helpful because doing a diagnostic wax up takes time and money, and a lot of people are not charging for that. So eventually we have to be profitable. So I hope that's a reasonable answer. So what you'll find is as you get better and better at Bioclear, you'll do fewer and fewer diagnostic wax ups. Abdurrahman and Pratik, would you agree?
Yeah, I would go for diagnostic wax up for the bigger cases, but not for copy paste, like to have an index, just have a picture for the final result. So like when you do the Bioclear cases without no increasing OVD, You should have picture before. So when you do the trimming for the first tooth, you should have reference how it was look like before, especially because for the canine, you should not lose your canine guidance. So how to do that? You should have an image in your big screen for the shape of the canine before you injected the composite. So you can just trim the excess to have the same shape that you had before. For the wax up, you like if you're doing wax up just to split the space, you can do that. So, but if you're doing wax up to increase the vertical dimension, um, um, you can like do the first tooth and trim it and finish it completely and measure the space between the cervical margin for the upper central to the cervical margin of the lower central to be exactly the same shape or the same for the same height for your articulator. So now you have the same OVD. And now you do the height of the teeth, and for the lateral, you just do it manually, like if you're doing equilibration for the patient directly in their mouths. So wax up would be like a reference, not complete way to go.
Yeah, part of a diagnostic wax up is so that you feel comfortable. It's more for the doctor to have a picture. Now, Abdurrahman said something else very important. You need to take lots of photographs. So we're doing less diagnostic wax ups, but more photographs, lots and lots of photographs, because those are extremely helpful for Bioclear. So that's a great question. Let's see what did people say. Abhishek,
most of the people says, can I?
Really?
Yes.
Really? Really? Because everybody, all the old dentists think, oh, no, David, you're a bad dentist. You have to have a gray incisal edge, right? We all thought that you were a bad dentist if you didn't have gray edges. Well, guess what? Patients don't want that. So we're 11 years later. We're 11 years later. She loves her tooth. She loves her tooth. So you know what's funny? Sometimes when I do a lecture, there'll be a person who his bias is that you have to have gray edges. And he says, I don't like your tooth. I don't like that peg lat. I don't like your lateral. And I say, I don't care, because she loved it. And she paid $110 for this, and the crowns are only $100. So she paid more than a crown fee for this. It's beautiful and healthy. I didn't cut the tooth. It could last for 30 years. So I don't care about the old world. I think the old world is awesome, but we're not worried about it because patients love Bioclear. Patients are asking for Bioclear. So it's a fun change, right? And these cases are, they're fun to do. So here she's 2009, 2018. It blends beautifully. Here we are, everyday class 3s. So there's the A102 and the A103 matrix HD. She needs to have her contact closed. So I'd like to put both matrices in, kind of like a diagnostic wax up. There's the small diamond wedge. I'm going to fill the lateral incisor first. And then I'll sculpt this back. In the old days, it would take me 20 minutes. Now, today, I can polish that back in 3 minutes. I'm going to be done in 3 minutes on that tooth. We're going to do progressive wedging. Went to a bigger wedge. Now I'm going to injection mold the central incisor. And this is just everyday dentistry. She had a lot of decay. She didn't really care about aesthetics. There's the immediate postoperative. As soon as the teeth rehydrate, it'll be perfect. It'll be a perfect match, perfectly healthy. I want you to look how broad the contact is right here. I also want you to look at normal dentistry. Do you see that filling right there that was done with the normal margin? That's ugly, okay? They thought that that was modern, but normal dentistry with margins is ugly. All these margins are going to stain. Hey, and people in India, they like tea. They like food with stain. I've been to India, okay? The food is awesome, but there's a lot of stuff that gets stained, okay? Especially that darn black tea, right? Oh, man, the stain is everywhere. You can't afford to have a margin in India, okay? You got to have infinity edges, right? Am I crazy or am I okay here?
You're okay here.
No more margins in India. It's against the law. All right. So we have lots of problem with composite, with voids and other problems, and that's why we do too many crowns. So why a method? Well, composite was thought of as a temporary material, like Abdul Rahman was saying, or Pratik was saying, that it was just temporary. We have a tipping point where things will change. So this is Dr. Les Miller, one of the graduates in the Learning Center. Look at the case that he did. That's amazing. Life-changing. And you know what? You don't want to put crowns on this guy. Even if he had $1 million, 1 trillion rupees, we're not going to do crowns on this guy. So let's take a look. The number one thing that people say about when they have black triangles is they look old, disease, neglect, poverty, lower IQ, genetic disorders. These are all the things that people say, even death. Black triangles look like death. You're like, really? Yeah. Black triangles look like death. So negative space is incredibly powerful to human beings. So we need to change our conversation and listen to our patients for a patient-centered outcome. Dr. Abdul Rahman's got a great presentation. We are technically running out of time on my end, but we're going to wrap up with Dr. Abdul Rahman's case. Why do we have to quit?
How to share the presentation? I don't know. I think, oh yes, there is share screen. Okay.
You know what?
You cannot start screen sharing while the other, yeah, you have to exit your sharing first, Dr. Clark.
So we're going to go ahead and let Abdul Rahman wrap up with his presentation. So I'm going to show some slides very quickly, and then we're going to shift over to Abdul Rahman's presentation.
Okay.
Oh, do we want, oh, Abdul Rahman's got a time limit?
Yeah.
So let's go ahead and show some of Abdul Rahman's work. And then if we have time, we'll come back and show this. Otherwise, we'll catch it at our next webinar, okay?
Okay.
Okay, so Abdul Rahman, now do I do a stop share?
Yeah, you have to do that, yeah.
Okay. All right, Ali, you're up.
Okay. So, okay. So I have only 2 cases, but it's like one of them 4 black triangle cases, maybe 60th for the lower anterior. I have done it 4 years ago. It was at the beginning of my Bioclear learning journey. So at the beginning, I was not confident about covering the whole tooth and how to manage the excess. And also, I wasn't using a lot of compules. I was doing a lot of packing with the twisted syringe, tried to pack it and open the matrix too much so I can push the composite inside the matrix zone. So even though with kind of a difficult way to apply your composite in the Bioclear method, I got a lot of good results with some mistakes that I want to share with you this mistake in the follow-up, because I have 3 years follow-up for this case. Definitely when you do the bonding, there's the Bioclear, the composite, the adhesive procedure, you have to have a good isolation. And without rubber dam, especially for the lower, you can do that for the upper without rubber dam if your patient is like 100% hygienic patient, which is rare in my country. I think it's really rare to have a patient that it doesn't bleed when you try to push something in his sulcus. So rubber dam is a must, and after that, you should take some picture, also pictures after the picture that you have taken before your treatment. And so you can follow your protocol later when you do the follow-up after 3 years or maybe 4 or 5 or 10 like Dr. Clark have done. So you can compare what you have done good and what you have done wrong, and you see how to manage, how to criticize your own work. This is how it goes. So if you didn't take picture, you cannot know which mistake you have done and which good thing you have done also. So I remember that when I started to do root canal filling, when I was an intern here. So I have a lot of cases that was doing very well, and a lot of cases that I have a lot of over-obturation. And then I asked a friend of mine that he was very good and honest, and I told him, I don't care only about the the bad cases. That's why it is went wrong, because actually I don't know how my good cases went in a good way. So I want also to know how to do it perfectly. So rubber dam in place, and it was a very deep decay. This is the picture before era prison. You can see here the plaque that it's been on the tooth surface, and after doing the isolation using some soft tissue clamps and doing blasting, you can see how clean the surface it became, so you can bond to this kind of surface. The space is huge. Definitely, we will go for the green matrix. It is a very huge space. At the beginning, some people will be confusing, not in these kind of spaces, maybe smaller spaces, which one of matrix that I want to use, green or ring. My advice to you, if you are confusing about the matrix selection, go for the green one. And if you found that it is more curved than you want it to be, just trim it to make it pink. But if you choose the pink, it will be no way back, and unfortunately you cannot sterilize the matrix. So if you try the matrix in the patient mouse, unless you keep it for the patient later on, if he has some black triangle later on, like, or you do some intentional black triangle so you can use the matrix, now you can fill with the space. So you have to be careful about that. So to my matrix, do the flowable hip, or to do the delayed wedging, like Dr. Clark have showing us the procedures. At that time, I was only using the thinner matrix, the 50 micron. It's much better to be confident for the contact, tightness of the contact, but it's easy to deform if you're not if you're not focusing to reshape the matrix after doing the injection. So make sure if you do the injection, like here, try to massage the matrix, like probably, so you can have. So you can see here that I was doing half. So I was not confident to cover the whole surface at one time. So I have to do the mesial, and do the matrix in the other surface, distal and distal. I did the injection probably. Does the connection is going well? You can hear me?
Yes, we can hear you.
Okay. Okay, so I did the injection probably, even I split it because I was not so confident. But the problem is all the composite that I added in the labial surface, I wanted to remove all the composite to reach the enamel and leave only the composite that in the plaque triangle area. So I lost the benefits of it. So tooth by tooth, and here the final, you can see that I reached the enamel, a lot of scratches. I couldn't polish. I went so deep proximal. I lost the line angle that the matrix actually gave it to me. I lost the polished surface in the proximal that the matrix gave to me, and I dismissed the patient. And here is the picture after 3 years. A lot of stains of the composite you can see here in this tooth, and also in that tooth, and even so, the patient always happy in some details. So I told her that I will do some polishing, but if you guys, we have to fix it with the composite. She said no, just do some polishing. So I did some polishing as much as I can, but I knew that I have done mistakes. I did the mistake that I didn't cover the whole labial surface, probably from the beginning by the injection, and I didn't finish it probably. Even I got a good composite on the labial surface, I was so focused to remove all the surface, like I don't want composite in my non-carious enamel surface, I don't want the composite in the surface that it wasn't it didn't have in the beginning negative space. So I learned it from this case, and also there is a lingual surface. You can see here that I almost remove all the composite in. For the lower interiors, you don't need to remove any lower composite. Even crown preparation. If you do a full mouth rehab and you have to do crown preparation for the lower, for the lingual, you don't have to do reduction for the lingual surface because you have a space to add porcelain without having any problem with the occlusion. So I don't know actually why I have done that, because my mind, like the old mind, was forcing me to do the composite in the way that I was taught to do in the dental school. So 6 years after Bioclear learning journey, here is my cousin. He did an ortho. I don't know, Dr. Clark in US, how many years the people usually do ortho treatment, because in Egypt there is some orthodontists do some long-term ortho treatment. He had the ortho for 9 years. I don't know how. Not to do ortho treatment, and I guess that he wasn't high caries index patient. I guess because of the ortho he got a lot of decay. I will show that he has the area that the bracket was bonded on the tooth surface. So he's doing a full mouth rehab. I have done for him an implant, crowns, and also Bioclear for the upper. So and he did it in 2 years. So every time he can afford, he can pay for amount of money. He do some treatment. But for the lower, I told him we have to do it once, so we can have not only in one visit, but we will do like tooth by tooth in each visit, because he cannot open too much, and also he has not enough time to stay for a long time in the dental office. So now you can see the difference in my Bioclear injection. I will show you now the way I do that. I did remove the biofilm, using the biofilm disclosing agent from the Bioclear, doing ear abrasion, choosing my aquarium. Now I'm going for the HD matrix, probably not the thinner matrix. However, you can use the thinner, but make sure that it will not invert, make sure that the matrix will not deform, because some people maybe will buy the thinner because it's a little cheaper, but it's not easy to push it cervically. So most of the cases, if you come from the country that usually, like my country, all the cases you have a deep decay that you have to push the matrix. And the thinner, if you bend the thinner, you cannot like reshape it again. But the thicker matrix, even if you got some deformation, you can just reshape it by your finger, or it can be go back for its original shape. So I did the first injection. Now I'm very confident about the extra composite. Like Dr. Craig said, before I was spending too much time to remove the excess. Now maybe in 5-10 minutes I can remove all the excess with the high speed per, almost with the high speed per, like 80% with the diamond per, and the less with the disc, softlex disc. So there's a lingual. I don't care. I'm not afraid about this kind of excessive composite. I know that I can remove it easily. First tooth done, and he went away. So we have done the first tooth. And usually, even if you are doing the full arch visits, if the patient can handle the long visits, it's very important to finish one tooth and remove the rubber damage, check the occlusion, check the reference. So because this tooth will be your like for the other four dentures, the canines, the differentiation, and make sure that you have the original picture in your screen so you can go back for it, because sometimes you lose. Because when you're finishing, especially if you're beginning of Bioclear learning journey, you might get upset and anxiety that takes too much. So you now you lose, you tell the incisal edge, or you use your reference. So now for the second tooth in another visit, we have done the lower arch in maybe 6 visits. He wanted that, but it's okay. We can handle this kind of time with him. So I removed the decay. There is some decay in each tooth because of the ortho. Also use my matrix, doing my way. There is no delay wedging here. The case was very easy, straightforward case. Do the flowable composite, do the injection, and remove the matrix, do your mark with the line angle, unlike pencil. Also, you can follow the debris like Dr. Clark is doing. I do my reference with the pencil to to mark the line angle that the matrix did it for me, so I will not touch it with my bear. You can do that. So don't touch the area with the pencil. It's your reference. Also ceramists, like we do in the course now, we use the pencil. Finish the second tooth and the patient. This is very bright picture. The camera thing was not good. My assistant changed it. So anyway, this is not the final picture. In the third visit, we did the other lateral in the right side, also the aquarium injection. I don't care. I don't afraid. I zero afraid of kind of excess composite. And somebody asked me, I did a live webinar a week ago for a group of people from Iraq, and they said it's too much composite. No, it's not too much if you don't want them, because like I don't want to waste my money to put composite that I don't want to I don't have to use, but I have to do a lot of composite. So I make sure that the composite that I will leave inside the aquarium is bite-free, monolithic. So it's not composite I won't throw it away. I paid for this composite, but I have to do it in that way. So finish the other lateral. I did the 2 lateral in 1 visit. He was able to stay longer, so we finished. And he was happy actually with the results. He told me it's very smooth teeth. He liked the reflection of the light, the polishing system with the magic mix from Bioclear, make the surface little bit smooth, and you get the pride and the brightness in the luster from the RS polisher. If you have it in your country, if you don't have it, you can use as the old one we had to use it with the Bioclear, or from Eve. The same concept, you can use it. Also, you have to do it in the new protocol. I think Dr. Clark can show us, and maybe later next week, how to do the polishing with the dry first, little pressure, and also with the water, with the more pressure. It gives you very, very good polished surface. Back like 3 years, 4 years ago, I used to spend 15 minutes to do my polishing, and even though I couldn't get the good polishing, I used to buy a lot of caps, probably time-based, 2 micron, 3 micron, 5 micron. You have to use 3 micron first, or 5 micron, then 3 micron. A lot of steps, and at the end, you don't get the result that you want the patient to have, and you just keep that, and you tell yourself that the saliva will do the job, and the patient will not see the difference. But the patient actually see the difference when he look to the picture, even when he use the mirror and he tried to look at these, and he see the reflection of the light, so he's happy. So now we have he has a class 3 and he did the ortho, but he didn't fix the teeth for 9 years, so he's still in the class 3. And and I checked my lateral, my anterior guidance. You have to do that to make sure that you don't have any high spots that the composite will not break. For the canine, there is the lingual. You can see that I kept the excess. I didn't remove any of the composite, just shape it for the proper shape, too bulky. And I kept all the tools with wrapped with the composite, all the tools. Only the incisal edge, because he was hitting it for the anterior guidance. For the canine, I did a mistake here, and how I fixed that mistake. I did the cavity. I placed my matrix, the one in the medial with the thinner matrix, the one in the distal with the thicker HD matrix. I used the wedge and I did the injection, and I got the good volume. The volume was very good, but I lost my reference. I don't know what happened, but anyway, I lost my reference, and you can see that he removed most of the composite that in the labial surface, in the middle, in the cervical one. Here we can do we can do that in ceramic cut pack. You can do some cut pack, like you do preparation, do like veneering with the composites, just the labial surface. You have many options here. You can use the Bioclear Matrix again if you want to, but you have to make sure if you got a good contact from the injection that you have done, you have to take the space. You can just have a regular matrix just to do the labial surface. So I choose the normal posterior matrix, the old one, to do my labial surface, and I did my polishing, the contour you can see here, that's much better. So that we call cutback. It's not allow for all the cases unless you know what you're doing. You have to a lot of enamel surface, fresh enamel surface. If you're not sure that you can do that with this kind of matrices, okay, you try to open the contact and try to expose a lot of enamel surface all around and try to anyway you have you can use whatever technique you want to do. But at the end, you should not make a mistake. The volume went so down that you lost the benefit of the overmolding of the composite in the labial surface. Now we do the case from the four. We had some decay in distal of the premolar, and also we had some space between the premolar and the canine. I used the premolar matrices, the 505, but I did some because the height was too high, so you should do some trimming from the cervical part, use some separator device to push the teeth a little bit, and you can see here that I in because when you do the injection, you can see that what you have seen in the matrix, you will see in the composites. Don't remove this composite. I don't know, you can see my arrow or not. So you can just remove this. You can do the upper one for all the tools, labial, distal, medial. The occlusal we had almost no care, just a small beta fissure decay from the ortho. So I did the finishing, and here's the final result after I finished the first premolar. And we went for the second premolar. I used only a wedge with no separator because I didn't close the space between the premolar and the canine. The space was a little bit huge, so we decided to leave it cleanseable, because if I over contour the canine a little bit and also over contour the premolar, and at the end will not able to close the space completely, I will make it more smaller space. I was not easy for the patient to clean. So it's much better to make it wider like it was before. So there is no food will trap it. So it's not easy. It will be more easy to clean. And here is the final result. He was so happy with the result. I'm doing implants for him, crowns for the other molars, and also crowns for the upper molars. Bioclear for the anterior, we still not finished that. This kind of patient, we come to you and you tell him that I will do crowns for you after 9 years of ortho, and you don't know how much you will remove the crown, because in this tiny space you can inject composite, but in this tiny space you cannot inject ceramic. You need pathway insertion ceramic, you need volume for the ceramic, because ceramic needs I think at least 1 millimeter if you're doing Emax, or maybe more for the incital or for the proximal. It depends how clever your technician he will be. And also these teeth is vital teeth. So you're not sure that if you do trimming you will lose the vitality, because in my experience with the teeth that it being stressed by a lot of forces, a lot of decay, if you do crowns, probably it will end up being endo-treated. This is my experience. So if for the posterior, teeth, for example, if I have a patient with all the amalgam filling with some decay, and I have to remove this amalgam filling, and we have to do some cuspal coverage, like 1 or 2 cusps, and do some partial caries removal. If we do composite with the Bioclear way, with some partial caries removal, and do the injection for the composite, the tooth will not lose the vitality. But if I do composite because I have to fill the gap and do preparation to do the cuspal coverage, most probably the patient end up with being in pain, and I will have to do endo. And the patient telling you that he came in the first place with no pain because the amalgam was there, the decay was there, but he had no pain. And you're telling them that you have to remove amalgam because there's some decay that you are seeing in the X-ray. So make sure that with the Bioclear, it's more safe for you, for the patient. We have a lot of cases that we have to do crowns because we cannot do the composite. We have a lot of cases that the patient asking for crowns, but you have to have all options that in your hand. Layering, if you have a patient who want to do some layering, just tell him that the pros and cons. I have done a lot of injection to a lot of dentists. I have a dentist of a friend of mine. He with me now in the lab. I told him to come to show you know the crack, the one with the two diastema that I have shown his case in the learning center. He's the best friend of mine, and he's telling his patient that he has done it for himself because he believes in the concept. So he's doing to them what he has accepted to have in his own teeth. He's a dentist. He can see that the Bioclear for him is a very good result, it is good result. But for the picky dentist that try to, even for this photo, we can see translucency, like Dr. Black said. We can see a good shape. We can see good line angles, good form. Why we should pack? Even if you try to pack, how much percentage that you can guarantee that you will get a good adapted composite in the X-ray, in clinical with the novites? How much percentage? How much time you need to teach some people to do layering? I don't know how much. I have seen a lot of people doing back angle, trying to play with the mylar strip, to twist it a little bit, do flowable spot, and twist it a little bit, do a lot of flowable spot. I don't know, Dr. Clark, if you have done that in the past or not, but there is some dentists doing this kind of stuff and trying to say to us that, it was a difficult case. Yeah, it was a difficult because it's using a difficult way. It's easy.
Hey, Ali. Okay, this is beautiful. We have to interrupt you. I wanted to, because we have to wrap up now, so I wanted to make a couple of comments. Can you put that picture back up, the one you just had?
The one lingo one, or
no, the facial one with all the shiny, with all the
okay,
yeah, with all the specular highlights.
Yeah.
So yeah, put that up for just a minute. So I want everyone to back up a little bit. And for Abdul Rahman, one of the reasons I wanted him to talk to you is because he did not invent the Bioclear method, and he learned the Bioclear method, but it took him a while to leave his old world behind. When you look at these teeth, his patient made two comments. Help me out here, Abdul, but he made two comments. First of all, he says, I love how they feel. They feel really smooth. And then he said, I also like how shiny they are. So these are called specular highlights. Specular highlights is the new layering. Specular highlights is the new polychromaticity. They're so beautiful to patients. So what we're talking about is a patient-centered aesthetic. We have a doctor-centered aesthetic. We have a bias that we think certain things look good. Patients love Bioclear for the feel. They love how smooth they are. People touch their teeth with their tongue a lot more than they look in a mirror at their teeth. So what Abdul Rahman on his journey figured out is that patients love the feel of the Bioclear restoration. And even though these were technically just these are just class 3 and class 4 composites, because Abdul Rahman did injection overmolding and covered the whole tooth, he's done additive dentistry. He's made the teeth a little bit larger. It's a new outcome. This tooth right here, this is a Bioclear crown essentially. And what Abdul Rahman was explaining is that it's actually simpler, faster, once you understand it, once you reprogram your brain, and the outcome can be as long lasting as a crown with almost no physiologic cost. So the challenge is for you and your practice is to start to think about this, to position your practice, market this as a Bioclear restoration. You need to start charging a crown fee for this, whatever you charge for your crown. I mean, I don't know what you charge for this, but eventually you'll figure out that this is as good as a crown and that your patients will pay for an outcome that they love.
I do charge like a crown, but I just like deducted the lab fees.
The lab fee, yeah. Yeah. So we're at a wrap point. Do we have any of our doctors that let's go to let's go out of the screen and go back to the view here. Go ahead and exit from share screen, Ali.
Okay. I actually I don't know how to exit. Yeah.
So, Carissa, what does he need to do? On the top of the
You need to stop your screen sharing.
Yeah, there you go.
Okay, actually I will have to go now because I have to go back to the layering ceramics. So we have to learn all the techniques in the industry. So
Thank you.
Thank you. Thank you, Abdul,
It was a
for your
pleasure.
valuable.
It was a pleasure to be with you guys, with the two crowd, with all guys in India. It's India. It's almost like my second country. I've been there for like 4 or 5 times. And so till waiting you next week in Wednesday. Have a good time.
Yes.
See you next week. Thank you.
Bye-bye.
Thank you once
Bye.
again.
So, Dr. Pratik,
Sir.
I will turn the time over to you. We will get together next week, and I hope
Perfect.
people enjoyed hearing from Abdul Rahman, because he's on his journey. And next week, I'd like to see some of maybe some of Pratik, a couple of your cases, to show that the Bioclear method is actually something that is every dentist can learn how to do.
Yes. Next week, my cases.
So do we have any, if you want to go ahead and tell us, you can do the end for us here. You can wrap it up for us, Pratik.
So Dr. Abhishek, can you take it over from
Yes.
here?
Yes. Thank you, David, for your wonderful time and demonstration. It was really wonderful. Surely you will see me next time as a Bioclear user very soon, once this lockdown period ends.
Very good. All right. So we will see you all next week. If you have questions, you can email us. The recording of this will be available, and we'll make
Yes,
sure
we will be waiting for that. Yes.
we'll have
a lot of people want to see the finishing protocol. So probably next week we will have the finishing protocol in detail.
Yes, we'll go ahead and we'll show the finishing protocol. I think everyone will want to see that. So we'll do a demonstration on that. We won't be able to have it full screen, but we may show what we probably will show is a pre-recorded Rockstar Polish video,
Yes.
and that will show the finishing, so that because we can't show anything full screen.
No problem.
Okay. Perfect.
All right.
Thank you so much once again, gentlemen. And before we finish it off for today, I have one last 30 minutes announcement to make. Tomorrow we have Christian Coachman, dentist, family who's practicing from last 170 years. We will be having a panel discussion with Dr. Rajiv Verma on DST, 9:30 p.m. India time. Thank you, David, once again. Thank you, Dr. Pratik.
Thank you, Dr. Clark, for making it this early. Next time we'll have it starting a little bit late for you. Hopefully with a little smaller mug of your coffee.
Okay.